Okay, thank you for Aldo and company for inviting me to talk to you all today. And I have the pleasure of talking to you about Daratumumab, another monoclonal antibody in the fight against myeloma. I'm afraid much of what I'm going to say is a bit of a repetition since elotuzumab works in a similar method. So Donna and I didn't coordinate, not even in terms of dress. We could have called each other and worn the same color, but we didn't. So the talk may be a little bit complimentary. I apologize for that. So Daratumumab belongs to a class of therapy called immunotherapy. And if you look up in the Merriam-Webster dictionary what immunotherapy does, or what it means rather, this is the definition you get: the treatment or prevention of a disease by taking measures to increase the immune system functioning. So that's a very broad definition. In the past, in the very recent past, we had really no understanding of how to actually leverage the immune system to do what we want. Now we're in an era where we can actually engineer molecules, treatments, cells even, to do what we want and harness the power of the immune system, as you'll see. So what is the immune system? To understand immunotherapy, you have to understand a little bit of what the immune system means. It's a nice catch-all phrase. We see it all the time in nutritional supplements: boost the immune system, but we don't know what that means. What does that mean? So the immune system has really three components. It's made up of organs, cells, and molecules that we can see here. And those are the three components, the basic components of the immune system. These are very complicated. They interact with each other. The organs would involve the organs that produce the cells, so the bone marrow, where most of these cells are born. The organs which educate the cells of the immune system. Here we're talking about the thymus, the spleen, and the lymph nodes. This is where they encounter foreign cells. Antigens are part of foreignness, bacteria, viruses, and even cancer. And they train themselves to fight against these agents in these secondary organs. The cells themselves are rather diverse. We have T lymphocytes. These are the cells that will go and actually destroy cells. NK cells, which are very similar to T lymphocytes. We have the B lymphocytes, which when they differentiate, that is, they become very mature, produce antibodies. And as you know, these are the cells that are responsible for multiple myeloma. So the cells themselves, the myeloma cells themselves, are part of that immune puzzle, if you like. And then the macrophages as well, which is another arm of the immune system, which can be involved in the destruction of bad cells. Molecules, I'm just giving you one example here. It's a very complicated network of different molecules that either aid these cells or antibodies that we'll talk about in lysing or destroying cells, or they signal in some way to say, hey, there's an invader, there's something that's foreign in there. So it's a very complicated network that we don't pretend to fully understand, but which we try rather crudely to harness and beat the disease. So this is a little electron micrograph of a macrophage, if you want, destroying a cancer cell. The cancer cell is the spiky little thing in the middle. Not little, it's quite big. There's some red blood cells around, and there's some macrophages that are actually destroying it. So most cancers evade this process. Cancers that become cancers really escape this process. Can we somehow cause that cancer cell now to be recognized by the immune system, whereas before it was unrecognizable? So to do that, one of the mechanisms is, again, the antibody. And it's ironic, as Dr. Rees mentioned, that the very molecule that is produced by the disease is now being exploited to actually treat the disease. And this is a cartoon on the left of an antibody. It looks the same as the monoclonal antibody that's produced by myeloma, or as well the antibody that's produced by the normal immune system. It's got a business end, as I call it. That's the binding surface, and that is what is trained against the foreign or cancerous material. And then on the bottom end is where it binds to cells that effectuate the destruction of whatever it is it's supposed to destroy. It's a nice cartoon. On the right, we have the actual image of an antibody with all of its different molecules that are linked together to actually produce this antibody. So what we try and do in cancer immunotherapy by using antibodies is we do we have a little laser pointer? I don't, eh? Oh, there we go. Yeah, but it'll point to one thing. Okay. So we engineer an antibody here that will be the link, if you want, between the cells of the immune system and the target cancer cell. So that antibody will recognize some antigen. An antigen is just a molecule on the surface of a cell that is more particular for the cancer as opposed to normal cells that are in the body. We don't want to destroy every cell in the body. We want to be able to pick out the ones we want. And the business end of the antibody binds to that molecule on the cell, and then the other end of the antibody, the non-business end, will then signal to a destructive cell. In this case, it's an NK cell, which will come along and destroy that complex. So that's the principle behind immunotherapy or monoclonal immunotherapy. To produce monoclonal antibodies, traditionally, what has been done is mice have been immunized. They've been given an antigen that is foreign to them, and we harvest their B cells, that is the cells that will produce an antibody, and we fuse them to myeloma cells. Again, ironically, why myeloma cells? Because they're antibody-producing factories. So again, this is the irony between the actual disease that we're treating and the process in which we're using to treat it. That gives us a new cell that then produces lots of monoclonal antibodies that are identical to each other and will be very targeted towards their molecule on the surface of the designated cell. For a lot of the newer therapies, we don't actually use this process. This process actually produces a mouse antibody, which our body will see as foreign and will react to. We have much more sophisticated ways of producing these antibodies so that they're entirely human and that we don't react to them. So one of these human monoclonal antibodies is Daratumumab. So Daratumumab is a molecule that an antibody that recognizes CD38 at the surface of plasma cells or myeloma cells, and then allow, in terms of mechanism, I'll try and go on this side, but I think it's a little bit oblique. So it allows the cells, as I've mentioned, of the immune system to recognize the target cell and then destroy it. It allows also some of the molecules of the immune system to bind to the antibody and also destroy the cell. And in a mechanism that may be unique or not unique to Daratumumab, we're learning more about how it works. It also changes the milieu, the immune milieu, where it allows, or it prevents rather, a lot of the suppressors of the immune system from globally suppressing anti-cancer immunity. So it may be that this molecule actually promotes immunity and then goes and finds the antibody bound to its target cancer cell and then destroys it. So multiple effects to actually destroy myeloma. So we'll talk briefly about two clinical trials, and these are the trials, these are early phase trials, not the big phase 3 trials that were presented a few minutes ago by my colleagues, but these are much more precocious trials, both of which aim to look at safety, but also at some efficacy of the drug. And these are the trials that were so impressive that the FDA actually permitted the use of this medication, so the approval of this medication based on these two trials. So here I've put the two trials together, and they're pretty similar. The first one on the left, the Gen 501, again, these are open label trials. Patients knew what they were getting. And the phase 1 portion looked at the safety and also looked at the dosing. So the dosing of the drug was escalated until we found a safe dose and an effective dose. Same for the Sirius trial, where the first portion of the trial, this is the trial on the right, also looked at dose finding, looked at the 8 milligram per kilogram dose as well as the 16 milligram per kilogram dose. And both trials came to the conclusion that the correct dose, so the dose that gave us, if you want, the most bang for our buck, is the 16 milligram per kilogram dose, and was safe to give to patients. So in all, about 148 patients were assigned to the 16 milligram per kilogram dose of this monoclonal antibody. In these trials, patients were quite refractory to therapy. Many of them have had 4 or 5 lines of therapy, and all of them were exposed to a proteasome inhibitor such as Velcade or bortezomib or carfilzomib, and IMiDs such as thalidomide, lenalidomide, or pomalidomide. The infusion schedule is a little bit onerous, especially the first infusions. These are very, very long infusions, the first one. And we give it weekly for 8 weeks. We follow that between week 9 and 24 every 2 weeks. And after the 24th week, it's once a week. It becomes much easier. After the first dose, which is quite long, and I'll tell you why afterwards, it's because of infusional reactions. The infusional reactions become less common, and we can shorten the duration of the infusion to just a few hours. So these are the characteristics of the trials of the patients that were included, and you can see very easily in the bottom part that all of the patients had or were exposed to a proteasome inhibitor in both of these trials, so either bortezomib or carfilzomib, and all of the patients had seen lenalidomide or pomalidomide or thalidomide. Virtually all of them had seen lenalidomide. So these are patients that are very heavily pretreated, that traditionally don't respond to anything at all that we have in our bag of tricks. These are again patients that don't have many more options. And despite that, first I'll go over the safety, because that really is the most important aspect of these early phase trials. And overall, we were quite pleased with the safety profile of the drug. The most important thing to remember is that half of the patient had some form of infusional-related reaction, and half of these reactions occurred within the first hour. So these reactions can vary from cough to shortness of breath to a rash. So things that are related to the infusion of the antibody, a reaction. We pre-treat the patient to prevent them. We treat the reactions when they occur, and hopefully they are manageable and we can continue the infusion, and they become less important on the second, third, and fourth infusions. So what is the response? You may find this a little unimpressive, but again, remember that these patients don't respond to anything else at this point. And the overall response rate is 31%. So that is almost 1/3 of the patients responded to the drug as a single agent. This is just the Daratumumab on its own. And the progression-free survival overall, that's responders and non-responders, everybody together, is 7 months. Which is again quite impressive for this population. There were a couple of complete responders. I'm happy to say one of our patients in our center was a complete responder, and in the patients that did respond and had very deep responses, they stayed that way for quite a long time. Can we make this better? Can we translate or extend that 30% overall survival to something deeper, more generalizable? The answer is probably yes. And the next question is, how